Introduce you to Chris Khoury, Vice President, Environmental Intelligence and Strategic Analytics at the American Medical Association. He focuses broadly on healthcare and business trends and their impacts on practice of medicine and public health. Christopher oversees a number of initiatives, including intelligence gathering and market research, industry analytics, strategic partnering, and innovation activities for the AMA. Prior to joining the AMA, he began his career as a product development engineer at an advanced diagnostic company, Nanosphere Inc., and subsequently has managed as a management consultant and healthcare researcher at Gallup Inc. and PricewaterhouseCoopers LLP. Christopher holds a BS/MS from the University of Illinois at Urbana-Champaign in electrical and computer engineering, and an MS in biomedical engineering from the University of Wisconsin-Madison, and an MBA magna cum laude from the Ohio State University. Chris is focused on helping physicians navigate the healthcare sector's rapidly changing landscape. And we know this world is changing rapidly, and particularly virtual care is also changing rapidly, as well as payment models for the future are also changing. So we are super excited to have Chris with us today. And with that, I'm going to pass it over to Chris. Thank you.
Great, Jen, thank you so much. I'm going to just get my slides up here, and you all can let me know that you're seeing them. Does that look good? Great. Thanks, Jen. And Jen, thank you so much for the warm introduction, and congratulations on what is shaping up to be a really great few days on exactly the topic of virtual care. Really glad to be here this morning, presenting to you virtually. As Jen said, I lead up a strategic insights group at the American Medical Association based in Washington, D.C. here. Similar to the disclosures Jen just commented on, flashing these on the screen here so you're all aware of these. And before I get into the overall narrative here, I just want to share one or two slides on who we are. Most of you know the AMA by name. This is our mission. It's really a dual mission around the health of the nation and ultimately the art and science of medicine, really what physicians do every day. We got our start probably now 177 years ago, if I got it right, with a first product, the Code of Medical Ethics. We've come a long way since then. This is the latest version of the Code of Medical Ethics that you can see our production quality has gone up quite a bit since the 1800s. But this remains the kind of core of in the backdrop of so much of what we do on behalf of patients and physicians. So we're here today to talk about the future of virtual care. But to get there, we have to first understand some critical underpinnings, and then we will go and look at the current landscape, and I think in the Q&A we'll be able to speculate a bit further as to what may be coming.
Chris,
yes.
Sorry to interrupt. I think you want to swap your displays on your PowerPoint.
Do something like that would happen. Okay, how's
there you
that?
Go. Perfect. Thank you.
Okay, thank you for calling that out. Let's see. Okay, we're good. So as I said, we won't be able to cover every exhaustive detail, but today is about making connections between different patterns and trends that we see out there. And that's what we'll attempt to do in the next 15, 20 minutes or so. So we'll start at a pretty high level. We're going to start very zoomed out and just kind of understand the landscape. We've all been through a lot these past 3 years. Particularly those who are on those front lines of providers. We thank you all, many of you who may be on this call and in this event today. So let's start at a high level. It's been kind of a seesaw for certain macroeconomic trends. Labor supply has actually begun to balance back out. There were significant labor shortages, you can see at a very high level, that is beginning to even back out in the past 5-6 months or so, particularly. The other big question on many folks' minds, if you're running an organization, you're an employee or whatever you may find yourself is, are we beyond the point of a recession? And well, here's a couple different data points here. There's a consensus out there that suggests that there's still a relatively high probability as of June 2023, above 60%. But one particular major economic investment firm suggests that it's significantly lower. Don't know exactly where that will land, but worth noting that there's a few different viewpoints on whether we are in or out of a recession. The other thing I think I probably don't need to emphasize too much for you all is this kind of headline that suggests that we will reach something like $6.7 trillion in healthcare expenditures nationwide by 2030. This growth, as you can see, is largely in that green area: health insurance, out-of-pocket, third-party payers and programs. The green bar chart is growth. On the right-hand side, I was looking at some specifics for California, and these specifics do not include health insurance premiums and so on, but suggest that the growth is happening again over the past 10 years across a number of different dimensions, all the way from 2% to 11% in different categories. So we know it's all growing. It's going to reach 20% of the economy nationwide, also by in a number of years, short number of years. And I apologize in advance, this slide is a busy one, but that's largely because physicians and other providers are busy and bogged down with all of the things on this slide in the real world, right? So this is a real opportunity for virtual care. Physicians face a number of obstacles in practice today, and providers of all sorts do so, ranging from prior authorization headaches, documentation burdens, the staffing issues that many systems and providers struggle with, in addition to the continued effects of institutional and structural racism, not only for their patients, but in the workplace and work environment. And what all of these burdens and structural determinants lead to is widespread burnout. AMA does studies every 3 years here. This is another study from Medscape, but they all basically say something similar, which is there is widespread burnout in the provider community. It varies based on specialty and setting and so on, but it is a very real problem. Thinking big picture, though, it's not exclusive just to the professionals in the workforce. This is a very recent survey from Deloitte on the right-hand side that suggests that this burnout phenomenon is being experienced by Gen Zs and millennials, really the next generation of our healthcare workforce, current and next generation, who are experiencing these very same symptoms. Again, these macro level issues play out at a very local level, but at the same time, we hope opportunities for improvement. Practice sizes are all shifting in a direction where they are getting larger. This is driven by the need to survive in an economic environment today, but also the phenomenon of further consolidation of different healthcare practices, acquisitions by larger systems and private equity. And this, of course, has implications for the adoption and implementation of virtual care services. In a best case scenario, there are more resources to implement technological change that allows for virtual care coverage. Again, provider space on the left-hand side, these are trends focused on private equity and acquisitions by private equity and other investors in providers and other healthcare spaces. So the dominant set of activity and deal volume remains in the provider space. And so I did a little thought experiment just very quickly for all of you watching right now. I took 3 organizations that spent a total of about $7 billion in 2022. These are all recognizable names, Optum, Humana, and Amazon. And cumulatively, Optum, I think, spent $2 billion on a clinic, Kelsey-Seybold Clinic, Humana, $1.2 billion, Amazon, almost $4 billion on One Medical. All of these obviously have a component of not only value-based care, but service delivery through virtual means too. So really interesting to see how this much money being exchanged plays out in this space. So from private equity, let's move to health equity. I think this audience will not be surprised to see numbers like this. This is a model from Deloitte. There are a few different models out there, but this one suggests that the cost of inequities today, health inequities, are around over $300 billion and expected to grow to $1 trillion by 2040. Looking at California specifically, this was another robust study done across all states to really understand the state impact. And for any of you math challenged, that number on the left there for California is something like $40 billion and eating up a share of the California GDP of 1.3%. When you look at not only the racial and ethnic health disparities, but the disparities contributed from lack of educational opportunities, it is much bigger. So some food for thought there of why this matters fundamentally. And I think it's also important to recognize that the way bias plays out in our health system today, there are opportunities for bias in the structures we have today, left and right. But you need not have a ChatGPT or a very sophisticated algorithm to introduce bias. This is an example of one particular health system's outcomes related to simply blood oxygen measurement within a health system. So very established, relatively simple algorithms, relatively simple devices can introduce dramatic bias in the outcomes of patients depending on their race and ethnicity, and room for improvement there. So what are we all trying to go to? We're trying to go from race-based medicine to race-conscious medicine. And this is work from scholars Cardenia and Tsai, physicians, that outline a path to race-conscious medicine. And you have to start on the left-hand side, understanding that race is not only a social construct, but one of power that influences us and builds structural racism before you can really get to the downstream changes to clinical practice that are needed. Thinking about virtual care, we have to apply the logic I just shared with you to the world of virtual care. And many of you will certainly understand that disparities and inequities could be introduced by things like inadequate access or access to broadband internet, for example. But it goes beyond that, especially in a place like California that is really a incubator of innovation and a hotbed of innovation. It matters how these products and solutions within virtual care are designed, who they're designed for, and thinking broadly about digital literacy and how populations you're trying to reach can adapt and use these devices. So important for us to think beyond simply just those straightforward indicators like broadband access. So let's get into the virtual care zone for a bit. And if you'll indulge me here for a second, the AMA has a particular lens on what providers need out of virtual care. And hopefully some of this will resonate with you, but it's really 4 questions. Most providers will be asking, does this work? Is there evidence for this particular care solution, virtual care solution or technology solution that I know is going to impact the patient outcomes that I want to see? They want to know if they're going to get payment and coverage for it, that it's tied to payment models, whether those be value-based care models or otherwise. They want to understand what their liability is. in the use of a new technology or in a new information stream. Because remember, there's data underpinnings here in addition to applications and technology. And finally, they want to know that it's not going to make their practice, all those administrative burdens that we showed earlier, that their practice is able to, that these technologies can integrate smoothly and not cause upheaval in the operation of their practices. So that's a lens. I am optimistic, right? So again, part of my job is to understand what the evidence base says about evolving technologies like virtual care. This was a study here on the right. I know it's a lot of numbers, but the big headline takeaway again is when you look at quality measures that are collected today, and you look at a large set of patient populations that saw either in-person only or telemedicine exposed, which could be entirely virtual or some blend of virtual and in-person, many of these quality indicators turn out positive in favor of the telemedicine or virtual care exposed patient population. And there's some statistics behind this, but it's encouraging that we can look at this existing set of quality, kind of ubiquitous quality measures and see these types of outcomes for the most part. Now, again, I can't go through materials like this without commenting on the tremendous investment environment that's out there. The numbers you see are really just trying to outline the dollars that have been invested, not everywhere. This is actually an undercount. These are dollars invested in private companies, think venture capital backed Silicon Valley type companies. And it's been tremendous for a number of years now. The cumulative investment is very large in the tens of billions of dollars. It reached a peak for a number of reasons in 2021, partly driven by the COVID environment we were in, but also just the access of cheap capital to invest with. You can see it's still substantial, though, even though it's gone down into 2023, it's still in the billions. Now, where is all that money going? When we talk about virtual care, it can be a number of different categories here. So the dominant volume and dollars are flowing into care delivery technologies. But there's still substantial money, sort of a distant second, in monitoring and diagnostics technology. You can see the other categories there that have really received a lot of investment. This is just in the first quarter 2023. Worth a shout out to folks on the West Coast here, that the Bay Area remains kind of the #1 destination for these dollars to flow in health tech. And not a surprise there. So again, to zoom in a little bit, let's take two really powerful players. You all know Mayo Clinic. You all certainly know Amazon. Let's kind of at least get a snapshot of where they are spending their money as these very large providers or corporations. And on the left-hand side is Mayo. You can see, don't worry about the logos, but really the categories there in the yellow box: diagnostic technology and wellness, health data and analytics, monitoring systems, surgical intelligence, and virtual and hybrid care. On the other hand, Amazon, I mentioned the One Medical acquisition there. There's some overlap given Amazon's footprint in data and cloud technologies. But you can also see things like pharmacy, PillPack, which was a major acquisition, and certainly remote monitoring, given the focus on home embedded technologies. So just a window into players with deep pockets here and what they're doing. Going back to the provider community, again, I think this is probably intuitively obvious to many of you who are in provider environments, but we've measured digital health adoption in 3 different times, the most recent one here in 2022. And televisits, virtual visits have skyrocketed. Again, not a surprise there, but it's worth noting that all of the different categories, including remote monitoring, the decision support, point of care workflow enhancement, and so on, have all gone up in exactly the trajectory you would expect for providers there. So this is the percent that are currently using these technologies. I think the other thing I wanted to flag, again, don't worry about all the categories on this slide, but we began asking these a question of providers in terms of what motivates them to adopt these technologies, virtual care technologies. And I highlight two things. One is value-based care. They want to know that it's going to enable them to participate in value-based care models more effectively, but also equally positive, I think, is that they want to know that it's going to help make an indentation on health equity work and allow them to do a better job in that domain. So positive to see that. So that kind of wraps me up here. And I just wanted to end with something fun here. All of you who are listening to this today, we are all building a future. We know healthcare as a system is incredibly complicated and frustrating sometimes. But I think we have two choices here, either to sort of smash together on the left-hand side or build something chimeric that is much more powerful. So I hope we can all do that. So thank you very much. Jen, I'll hand it back to you right now.
Chris, thank you so much. Well, my brain is spinning and I've got a bunch of questions for you. But I want to again encourage the audience to put your questions in the chat, or if you'd like to come off Zoom and ask your question, please feel free to do so. I ask that you raise your hand and we'll get you into the queue. Lots of questions though, and because I geek out over this stuff. I think I'll start with the end, which was your teaser around virtual care. And as you know, California has leaned into their new 1115 waiver, which we call CalAIM. And California also extended flexibilities around telehealth utilization. How do you kind of see that? And, how does AMA see the future of telehealth and access of telehealth? And do you have any more insights that you would like to share with this group around that?
Yeah, I mean, I think California, like many other times, tends to be a leader in a lot of ways here. I can say that AMA was, very supportive of extending the telehealth waivers. We thought that was very important for telehealth to really take root nationwide. And right now, I think our focus is on supporting physicians and practices that are still operating and really going through an organizational transformation in the way they deliver care. And we don't have quite the same pieces at play that we had during the health IT movement of the past 15 years or so, 20 years now, I suppose, that not the same support structure. So we are finding ourselves developing really practical tools for physicians to do this well in all the domains I talked about.
Great. One of the things you also touched about was the economics of health equity. And I can't tell you how tickled that makes me to see. Anything else you want to lift up for this group around the economics of health equity and how it ties into virtual care access? What are you seeing from your lens?
Yeah, and I share the economic slides because I agree. I do think they need to be elevated because we are in an environment where dollars shape the conversation, right? The decisions that are being made, certainly at health system levels, at policy levels. It's really important to understand that there is a global penalty that impacts us all when health equity is not prioritized, when the same structures that have enabled these inequities are allowed to persist. So I think I'm glad that we're at a point now where high quality studies can quantify this work. We all know what the right thing is to do, but we're also now equipped with not only the rationale and the arguments, but much better tools. I can just elevate one other thing, which is we have an initiative right now that is focused on the embedding of health equity practices and principles within quality improvement departments and initiatives within health systems. And so I think those are examples where we need to use the existing structures where possible and find ways to embed equity into those structures so that it permeates through care delivery.
Love it. Love it. Okay, I'm lifting up a question from the chat. There are two of them in the chat. One is, prevention is better than cure. How can we use virtual care in prevention of NCDs in rural communities in the developing world?
Wow, I want to stare at that question for example. Is it in the?
It was sent to me. Why don't we hold that question, and then I'll get the.
Yeah,
that's definitely a big thinking question.
Well, I feel like, yeah, exactly, and I feel it's probably a little bit out of my certainly out of my expertise, but I think it's one of the things I think about is that the minute you get out of the United States into other parts of the world and developing world, or the global South, you don't have a physician dominant environment. You have in some cases, environments that are upheld by other types of health, public health services, nursing workforce, and a general lack of access there, right? So there's a big need, but that strained environment, I think, means that some of the most advanced things are happening sometimes outside of the United States first. I think there's a lot we can learn, just leave it at that, from other environments that have dealt with all kinds of restrictions and resource limitations and have found ways to implement remote access, virtual care, remote monitoring, and so on.
So I want to build on the remote monitoring question, but coming back to the United States, and interestingly to see that both Mayo and Amazon have been building out that piece. Any trends or anything that you want to lift up regarding RPMs? What is the future RPMs? Any thoughts that you might have on that?
Yeah, I mean, let's see. We're in an interesting place right now. I think it's easy to get enamored or enamored with advanced cutting edge technologies. I mean, I think, for instance, continuous glucose monitoring has come a really long way. Here's an example of something kind of in the weeds that I didn't know about before. New fact for me is that prior versions of continuous glucose monitoring devices required sensor warm-up. So think about times in the days when folks' glucose levels spike up or down in the mornings or at night. But there's a warm-up period that was required. As the technology gets more advanced, that warm-up period shrinks, which means that you're lowering the risk in the danger zone of folks not having that real-time information. So that was kind of a light bulb for me, is yes, technology does matter. At the same time, things, work we do at the AMA with blood pressure control, remote monitoring, that's simple. You don't necessarily need a Bluetooth connected device in an advanced app. You need to measure your blood pressure at home properly. You can record it with a pen and paper and provide that to your physician and track it. So I think there's room for a wide range of technology applications here, and they need not be costly.
Excellent. Excellent. I'm going to go back to the chat and lift up a question. Can providers move to sustainability without telehealth or other virtual services in their practice? Specifically when moving to value-based pay where better outcomes are required while bending cost. Can virtual tools increase earlier access and lowering cost?
Yeah, well, it seems like the ship has sailed in the sense that we've crossed a chasm, or whatever the expression might be, where these tools are widely available now to providers. And they come in all flavors. There are big institutional implementations of virtual care platforms, and there are very kind of low-cost implementations where the two-way video is allowed to work, but the billing and payment is still done in a traditional way on the back end. You're just sort of leveraging an approved technology that happens to work on your phone. So it feels like we are already at a place where most physicians, if they weren't previously, and providers broadly, they weren't previously comfortable with this, have gotten there for the most part. So, and I think it is, from everything I know today, that it needs to be an underpinning. There's a lot of work that's been done on the burden of measuring, performance measurement for quality and value-based care performance. The more we can do that seamlessly and silently behind the scenes, I think virtual care tools can really assist in that and sort of get us to where I think CMS would like us to be in by, what is it, 2040 or whenever or sooner.
That's great.
Yeah.
We agree at OCHIN. So and CTRC. So one of the big beasts that we didn't talk about in terms of looking futuristic is artificial intelligence. I'd love to get your thoughts on how AI might impact telehealth and the future of virtual care, and any other things that you would like to bring up regarding the big elephant in the room that kind of looms over all of us, which is artificial intelligence.
Right. And I was hoping we might get there in that conversation, because, I fully acknowledge that everybody is speculating right now, but I really do believe we've had a fundamental inflection point in really the past 6 months. We're in an era where, we're talking about large language models. Everyone, the sort of most familiar implementation, that's ChatGPT. The big picture here is that for the first time, your average human can interact and guide a very sophisticated model using plain language. So it isn't just, can I talk to Siri and can I talk to my, home speaker at home to order a pizza? You can engage in much more complicated activities and guide and actually train the model using plain language. And that's a game changer compared to where we were at. We were talking about deep learning for many years, still are, machine learning, where you still needed to have a degree of, essentially a computer science degree or a master's degree or more to do something meaningful there. So we are in a fundamentally different era in terms of how these things are accessible to your average human or to your average expert, like a physician and other health professionals. That's different. It seems like we're still in early days to how it will shape virtual care. You can certainly imagine a world, though, where in the past patients, we would joke about them, talking to Dr. Google and Googling their symptoms, to get a big list, and they would still have to use their brains to kind of sort through that and make some judgments and say, oh, I want to choose the Mayo Clinic link or the WebMD link or the AMA link to learn more about this. Now you have a scenario where they're consulting Dr. GPT, and that choice is gone now. You're getting the output of a model that is optimized in some way, but in a way we don't know. So we still have a black box problem. Not in every model, but in the ones that are dominant right now. The thing that kind of keeps me up at night, this is more of a, at a professional level, you may have models. The first thing to know is these models are trained on things that are 1 to 2 years old. So the science and the knowledge stops a couple years ago, depending on what flavor you're using. So think about medical knowledge. Let's think about long COVID, for example, what we know about it today, or other things. The knowledge is partially stopped there in terms of how it was trained. The other thing is, as an organization that publishes things like JAMA, the body of medical literature, and biomedical knowledge, some of these models are trained on preprints, for example, because they're freely available publications that have not gone through the full editorial process. What happens if a publication is retracted because there's an error in it or some information changed then? How do we know the model's been updated that way? And that seems kind of like minutia, but you're talking about knowledge models here, and it is something we have to be really concerned with.
Yeah, and bias, right? I mean,
Yeah.
the bias in the algorithm, and yeah. Do you see opportunities to advance virtual care with AI?
Absolutely. I think there are still a lot of opportunities. You think about the workflow and a lot of the administrative burdens we had that physicians and providers all face. You could imagine all the things that happen in between a virtual care encounter that require follow-up, whether it's medication adherence and questions around prescriptions, or following a particular, therapeutic regimen after they've been discharged. There's a lot of opportunities for friendly chat-like things to help fill in the blanks in between those provider encounters, and do it in an authentic way that gets the right behavioral outcomes you're trying to achieve. So that seems like a big deal, because it's no longer about that one encounter over video remotely. It's about all the other touch points you can potentially have with a patient with this type of augmentation.
Is super mind-blowing what could actually happen. And then, one of the areas that's also under scrutiny is the impact of AI on the workforce. You showed a little bit about provider burden, but any thoughts on workforce needs and what that might mean?
Yeah, and Jen, I just want to say, you've kind of reminded me that there are lots of reasons to be optimistic here too. I mean, we always try to have a balanced view and a level head here. Certainly at my organization, but also just, not to fall into the trap of what they might call techno solutionism, assuming that everything can simply be solved by, more computing power, right? But absolutely, given the state of our workforce today, the levels of burnout, I really think that we need to get this right. I'm encouraged that I think a lot of physicians now are less, they're not asking the question of, am I going to be replaced or not? I think they've moved on to a deeper understanding and putting their scientist hat on, to begin to ask, begin to articulate what they need out of this technology. And I think that's really important, that health professionals of all stripes don't worry about whether you're an expert or not in the underpinnings and underlying technology of these platforms. You're an expert in what you do every day, and that needs to be conveyed and amplified to the technologists that are building these solutions. So our voices, even if it's outside of our sweet spot, are even more important today.
I love that. And I'll make a connection with all the platforms to try to address social needs of patients. You still need people to connect with people to address their social needs. And technology is not the solution. It's a facilitator to better care and better access. So I appreciate you lifting that up. Going back to the chat, so I see that Teresa has a question. Chris, in the US, we're seeing private health insurance plans merging and controlling provider payments, which are not increasing to keep up with inflation. Do you see virtual care and telehealth services also being controlled by a few private payers who will again control and limit provider reimbursement? And what are some of the AMA strategies that you're looking at to help physicians and mid-level providers survive in this competitive market? So I guess it's a two-part question, but Teresa, you'd like to come off the chat and ask it, you're more than welcome to, and if you'd like to have more character around it.
Yeah, I'll give it a second here in case Dr. Velasquez would like to do that, or after I comment. Either way is fine. But thank you, Dr. Velasquez, for the question. I think it's reasonable to be cautious around how this all evolves. The nature of, I think, technologies in general, they start out a lot of times with that figure I showed you of all the investment in those amazing startups in Silicon Valley and San Diego and everywhere else. And those startups eventually, if the lucky few grow to be those unicorns and get really big, the other ones are acquired and sometimes folded into much larger entities. That type of consolidation has, the Amazon slide I showed, where some of the purchases they've made, that is going to continue to happen because, quite frankly, there's one last big piece of the economic pie for technology in this country and globally, and it's healthcare. It's a huge opportunity there. Sophisticated payers, won't mention their names, but you can think of many of them also understand this well, given the dominance of employee-sponsored health plans and the administrators for those. And I think it's a very complicated environment. The good news is that providers, out to get to your second question, I think providers now have these tools. You don't need to necessarily sign a big contract with a big consulting firm to implement this stuff anymore. There are really agile tools out there now that can be implemented fairly cheaply and quickly and efficiently, that allow providers to offer these services, get paid for them, and reach, attract more patients, keep their patient population engaged. So it is a little bit of a democratized environment, but we should always keep one ear, paying attention to what the biggest players with those deep pockets are doing to consolidate the marketplace here.
Always, always. Hey, I want to shift a little bit. There's a question in the chat. Our workforce needs are changing, and one of the things that was lifted up in the chat was around, Amazon and Mayo Clinic employing nurse practitioners. Any comment that you want to make around, AMA and the idea of being able to expand either practicing on top of license or expand access to other types of providers to deliver care? Anything you want to talk about or care to comment around?
Yeah, I think that I'll politely pass on that as a sweet spot, other than to say that AMA has a scope of practice partnership with a number of other specialty societies where all of these conversations are happening certainly at a policy level, to understand, what's ultimately best for the patient, and also what provides the best sort of level of care needed for a particular area.
Thanks, Chris. That's a tough question, and I appreciate you taking it. One of the things that, at least at the TCRC that we've been thinking about, California has its fair share of disasters and challenges, whether it was floods this fall or fires. I know at OCHIN, we've seen our health center sites burn down. How virtual care can, what's the role of virtual care in climate change? I don't know if you've thought that through, or, any thoughts that you might have around that.
Well, I love that. I think that's worthy of a full day's workshop, to be honest. And I would love to come to that workshop. So yeah, the personal anecdote is just last week I was traveling for my work in Chicago. The air was relatively good there. My spouse and two children were at home. They were the outdoor playground recess where my kids go to school was shut down because of the pollution, smoke pollution that had come in from Canada along the East Coast. And my older son has asthma, and this required active attention and treatment for him. We opened the front door and the air purifier, that would get triggered instantaneously. It was talk about direct impact. But your original question, so we're all feeling this. It doesn't matter who we are. That said, there are serious equity considerations here, how this plays out in cities and geographies where pollution, other climate change effects are not, while we're all vulnerable to it, they play out differently in different communities. And so there's that. The opportunity for virtual care, there is an opportunity for, similar to the continuous glucose monitoring example, where you're being proactive around management. we're certainly at a point now where air quality levels, asthma and COPD management, that could be much more sophisticated. People have been trying that for a number of years with GPS and integrating weather data, but that's certainly a thing. The other thing on climate change is that we forget that health systems, when there are climate disasters elsewhere in the world, it doesn't need to be in your backyard. Think about Puerto Rico, where it's a center for medical device and disposable manufacturing. When a hurricane devastates that island and the people there, the electricity is shut down, there are effects on the population, but those effects reverberate globally, including the supply chain. And so you need multiple options when in-person care can fall apart in these sort of most extreme examples. So a lot to unpack there. I wish I knew more, but I would say this is certainly an area AMA is taking very seriously on the public health and population effects of climate change.
Yeah, there is a lot to unpack with climate change, and it's interesting to see, to study this. We need a lot more data and understanding. So appreciate your commentary on that. Another area I'd love to explore with you as we're getting closer to time. And again, I want to encourage all participants, if you have a question for Chris, to please put it in the chat or come off of mute. We'd love to hear from you. One of the things that I would love for you to talk about is cyber and privacy, data and privacy. And whether you have anything that you would like to share about the future of virtual care when it comes to the continuous threats of cyber. It may be outside your realm, but I'm just curious because we were just talking about disaster recovery and disaster preparedness. And cyber attacks, unfortunately, are just the nature of our world now. It is part of our disaster preparedness. Anything you want to share with the group on your thoughts around cyber issues?
Right. Yeah, it's certainly a big issue. I don't have the trends at the top of my mind, but it's a really big deal for health systems and small providers and small clinic environments, public health environments who don't really have the resources necessarily to do everything that needs to be done on the prevention side. So the conventional wisdom is not if you will be attacked, but when, of course, right, in the cybersecurity world, and what your contingency plans will be there. It's not just, so you have, thinking about cybersecurity, you have the dimension of bad actors out there trying to cause harm or ransomware type attacks. But I'm forgetting about the specific virtual health provider, but there was a case also where they did not disclose that they'd embedded Facebook's tracking software code in their virtual care app. And that was violating patient privacy because that information around those encounters was flowing into Facebook's or Meta's software algorithms that manage advertisements and so on. So yes, there's the ransomware stuff, the bad actor stuff, but there's also, I think, things we're still learning around the fact that so many of these virtual tools are built using a stack of software and tools that are coming from a lot of different places. So there's risk there in terms of privacy, but there's also just vulnerabilities if it's not done well. I don't feel equipped to weigh in about how you do that exactly from a regulatory perspective, other than to say that software like this is very complex and isn't just something someone's doing on their computer. It uses a lot of different pieces to make it work. So the risk is really there.
Thank you.
Yeah.
So as provider shortages continue to grow, what are some proactive approaches that can be taken to train providers to prepare for the future?
Yeah, that's a good question. And again, these are hot topics, I would say, around the question of what do provider shortages look like in the future? Can we project accurately? It's sort of like someone said, is the future, is it lumpy or not? So provider shortages are lumpy in the sense that they're felt differently in other, different geographies. So it begs the question around how we've organized the provider community and how they can deliver care. Virtual care obviously has a big opportunity there to meet those shortages. But on the training side, it's a great question from this person. We've got, particularly at the AMA and other institutions, we've got a lot of energy and work with medical schools themselves. Not only on the provider shortage, so we've got it in a few different ways. One is training and residency programs that are being elevated to around rural care and reaching large geographies and rural environments. It's a certain type of training, but also incentives and other parts of the package that encourage those residents, once they're trained, to stay in those communities. But on the technology side, certainly, we are very committed as an organization, and it's truly needed to make sure that physicians and any health professionals that are being trained for the future now are equipped to know how to implement virtual care tools, trained to treat patients in that setting, but also trained to understand the future we've already talked about on artificial intelligence. How do you evaluate an algorithm properly and know whether it can be useful for your practice or your patient population? So there's a lot of knowledge development that needs to happen, and I'm excited that so many health systems at the continuing education level, but also medical schools, are really focused on this.
And it's another AI opportunity, actually, right? Is in the trading space.
Oh yeah, yeah. I mean, you think about, I'm just to riff on that for a second. I'm also excited about AI coaches and mentors. Like, think about the pipeline to medical education. It's still a rarefied field. We do not have enough physicians of color, particularly Black men, that are able to matriculate in medical school. Big opportunity there to go upstream and think about that high school and undergraduate environment and the type of support systems that can really benefit to build a more diverse physician population. So thank you.
I love workforce is lumpy. I'm going to use that advocacy moving forward. Workforce is lumpy. That's the
Try it out. Yeah. See if it works.
See it works.
Yeah.
I'm going to take one last question from the chat, and then I'm going to ask you to provide some final thoughts. So while I do that, looking at social determinants of health and telehealth, going back to equity for 1 second, what are the investments in innovation to address social determinants of health? I mentioned a little bit that sometimes technology is being used as the savior, but not necessarily it being panned out. But are you seeing technologies in this space that might be helpful, that we should think about in California as we are advancing health equity here in the state?
Yeah, it's a great question too. Think about one example here, and I discovered this in some work that others were doing at Duke University in sepsis. So stopping the onset of sepsis in a hospital environment, pediatric, adult, and how technologies can make a difference there. One of the big things is for populations of different backgrounds, particularly non-English speaking populations, you need to be able to have access to a high quality translator on the fly, and that can make the difference between life and death. Not just in sepsis, but you can think of a lot of other settings where that really matters in care delivery, and particularly community-based organizations that are have devoted their resources to serving these populations. So I get excited because I think there really is a big technological opportunity to make sure that those types of barriers, those are structural barriers that folks that are immigrant populations, refugees, non-English speaking populations, they're harmed by this right now. And so I'm optimistic that I think in the next couple of years that hopefully this type of problem will go away with technology and be accessible to regardless of what environment you may be in as a provider.
I love the optimism. Okay, the last thought, because we have 3 minutes left, and just thank you so much for being here today. Any parting words that you want to leave the California virtual care community with today, and maybe it's a opportunity or a view of hope, but any last thoughts that you want to share with the group?
Well, I just really appreciate the opportunity to speak with you all today. It's been a real pleasure. The questions were incredibly thoughtful. I've learned a lot from the questions you've given me, all something to think about too. I admire the work being done in California, broadly speaking. It's not just the technology environment, it's incredibly talented and dedicated healthcare workforce out there that I've been exposed to over the years. And I just want to thank you all for the commitment and the passion of what you all do and for really the future of America. I think think about frontline providers, you're frontline in many different dimensions, actually. And that's sort of how I always see California as kind of a beacon of what's possible. So
thank you, Chris. So with that, we're going to wrap it up. And thank you all for participating and all your great questions. And I will pass it back to Aislinn and the team.
Thank you.
Okay, thank you all so much. Join us for our next session at 10:15 a.m. Telehealth for vulnerable populations. We'll see you there. Thank you, Chris and Jennifer, for the great presentation.
Thank you.